Hello, good morning, everyone. Today we will be discussing about a very important topic in the physiotherapy in sports, that is sports injury prevention. We will be starting with the introduction. The sports injury prevention is to minimize activity-related injury, that is to improve the benefit, the risk ratio associated with physical activity in sports. Sports injury prevention can be characterized by being primary, secondary, and tertiary. In primary prevention include health promotion and injury prevention. Example, ankle braces being worn by an entire team, even those without previous ankle sprain. Secondary prevention can be defined as early diagnosis and intervention to limit the development of the disability or to reduce the risk of re-injury. Example, early rise treatment of an ankle sprain. The tertiary prevention is focus on rehabilitation to reduce and or correct an existing disability attributed to an underlying disease. Example, in the case of a patient who had an ankle sprain, this would refer to wobble board exercises and graduated return to sport after the initial treatment for the sprain. Here are the phases of prevention and sports injuries. First, warm up, then stretching, taping and bracing, protective equipment, suitable equipment, appropriate surface, appropriate training, adequate recovery, psychology, and nutrition. These all points are very important in aspect of sports injury prevention, and one should need to follow. First, the magnitude of problem must be identified as described in terms of the incidence and severity of the sports injuries. Second, the risk factor and re-injury mechanism that plays a part in causing sports injuries must be identified. Third point, to introduce measures that are likely to reduce future risk and or severity of sports injuries. Fourth point, the effect of measures must be evaluated by repeating the first step. Here, the sequence of prevention of sports injuries first is to establish the extent of injury, incidence, the severity, then to establish the etiology and mechanism of injury. Third is to introduce the preventive measures, and then finally we assess it and effectiveness by repeating the step one. Consider the internal risk factor. Factors that may predispose to or protect athlete from injury. This includes athlete characteristic factors such as age, maturation, gender, body composition, and fitness level. One factor that consistently has been documented to be a significant predictor is previous injury, almost regardless of the injury type study. Internal factors such as these interact to predispose or protect from injury. The internal risk factors can be modifiable and non-modifiable. The modifiable risk factors may be targeted by specific training methods. The non-modifiable factors are such as gender, can be used to target intervention measure to those athletes who are at an increased risk. The risk factors for injury, a comprehensive injury causation model based on the epidemiological model of Pierce and modified by Barr and Prosser. As we can see, the BMI, range of motion, the risk factor for an injury, the injury mechanism. We can see the internal risk factors can be age, gender, body composition, BMI, health, physical fitness, anatomy, skill level. Up in a predisposed athlete or susceptible athlete can lead to an injury. Exposure to external risk factors can be human factor, the protective equipment, example helmet, shin guards, sports equipment, skis, environment, snow, ice condition, floor, turf type, and maintenance. The existing event can be playing situation, opponent behavior, gross biomechanical description, or detailed biomechanics description. This can lead to an injury. The second group of risk factor is the external factor. The athlete are called in cold weather or inappropriate footwear, exposed to, for example, floor friction in indoor team sport, snow condition in alpine skiing, a slippery surface for a running track. Right. Exposure to such external risk factors may interact with the internal factor to make the athlete more or less susceptible to injury. When the intrinsic and extrinsic risk factors act simultaneously, the athlete is at a far greater risk of injury than when risk factors are present in the isolation. The final link in the chain of event is the insisting event, which is usually referred to as the injury mechanism. What we see when watching an injury situation. Again, it may be helpful to use comprehensive model to describe the inciting event, which accounts for the event leading to the injury situation. Playing situation, player and opponent behavior, as well as includes a description of whole body and joint biomechanics at the same time. For clinicians, this model can be used to identify potential causes of injury. The key question to ask are who is at an increased risk and why? How do injuries typically occur? When carrying a defined group of athletes, such as a soccer team or an alpine skiing team, this can be done using a systematic risk management approach. The individual risk factors and protective factors can be mapped during the pre-season physical examination. Example, history of previous injury, malignant, or tested as a part of the team's fitness testing program. Example, strength, flexibility, neuromuscular control. Then, it is possible to do a risk analysis to document the part of the season when athletes are at the greater risk of sustaining injuries as a result of the training or competitive programs. Example of situation in which risk increases are when athletes switch from one training surface to another. Example from grass to gravel or to new types of training. Example as start with the strength training period. The analysis is important basis for planning preventive measures, particularly for the purpose of avoiding overuse injury. The analysis is based on the idea that the risk of injuries is greater during transitional periods and that each stage has certain characteristics that may increase risk. The risk profile usually varies from sport to sport. The healthcare personnel responsible for teams or training groups should do this type of analysis in collaboration with the coaches and athletes and create a plan for relevant preventive measures based on the risk analysis. Then we start with the principles. First, the warm-up phase. A warm-up prepares the body for exercise. The type of exercise to be performed determining the type of warm-up. The most effective warm-up consists of both general and specific exercises. The general exercises may include jogging, general stretching, resistance training. The specific exercises include stretches and movements that are appropriate for the particular activity about to be undertaken. The possible benefits of warm-up prior to physical activity. That it increases blood flow to the muscles. It increases oxyhemoglobin breakdown with increased oxygen delivered to the muscles and increased circulation leading to decreased vascular resistance, increased release of oxygen from myoglobin. It enhanced cellular metabolism, reduced muscle viscosity leading to smoother muscle contraction and increased mechanical efficiency. The increased speed for nerve impulses. It increased sensitivity of nerve receptor, decreased activity of alpha fibers, and sensitivity of muscle to stretch. Decreased number of injuries due to increased range of motion, decreased stiffness of connective tissue, leading to decreased likelihood of tears. It increased cardiovascular response to sudden strenuous exercise, increased relaxation and concentration. In team sport, there can be a group of regime with a built-in period of pre-warm-up. One guidelines for the intensity of warm-up is to produce some mild sweating without fatigue. The effect of warm-up lasts approximately 30 minutes, so it is important not to warm up too early. The structured warm-up program designed to prevent injury can reduce injury risk by 50% or more. However, it is not known whether it is the psychological effect of the warm-up program as described above which confer the effect on the injury risk, or whether the reduced risk result from the training effect on strength, neuromuscular control, technique, or other factors. Next up is the stretching. It is the ability to move a joint smoothly throughout a full range of movement. It is considered an important component of good health. There is a hereditary component to general flexibility, and a specific joint or muscles may become stiff as a result of injury, overactivity, or inactivity. Athletes commonly perform three different types of stretching exercises. Example, static stretching, ballistic and proprioceptive, neuromuscular facilitation, the PNF stretching. First, we're going on to the static stretching. The stretch position is assumed slowly and gently and held for 30 to 60 seconds. The athlete should not experience any discomfort in the stretch muscle. As the position is held, tension from the stretch becomes strong enough to initiate the inverse meiotic stretch. Reflects with subsequent muscle relaxation. The muscle that can be stretched a little further again without discomfort. This increased stretch should be held for approximately 30 seconds, then relaxed. If during either stage of the stretch there is a feeling of tension or pain, overstretching is occurring and this may cause injury. The athlete should ease off to more comfortable position of the different type of stretches. Static stretch produces the least amount of tension and is probably the safest method of increasing the flexibility. Here is the ballistic stretching. In a ballistic stretch, the muscle is stretched to near its limit when stretched further with a bouncing movement. The disadvantage of the stretch is that quick bouncing can cause a strong reflex muscle contraction. Stretching a muscle against this increased tension heightens the chances of injury, therefore, the technique is not commonly used. It is usually used in the gymnast. The ballistic stretching may be used, however, by athletes in the later stages of stretching program. It should be preceded by adequate warm-up and slow static stretching. It is used particularly as in gymnastic, as we have discussed it earlier, the ballet and dance, where maximal range of motion is advantageous. The PNF stretching. Proprioceptive neuromuscular facilitation stretching is performed by alternating contraction and relaxation of both agonist and antagonist muscle. That muscle relaxation is increased both after agonist contraction and antagonist muscle contraction. There are the number of different PNF stretching and techniques. As we can see, PNF stretching may produce greater flexibility gains than other stretching and techniques. Its major disadvantage is that there is tendency to overstretch. PNF stretches should ideally be performed with a partner who is aware of the potential dangers of the technique. The PNF stretching is based on the observation. As you can see, the principle of stretching. The basic principle of stretching are warm up prior to stretching, stretch before any and after the exercise of an event, stretch gently and slowly, stretch to the point of tension but never pain. A general stretching program involving stretch are the major muscle groups. Here, as you can see in the figure 6.4, the PNF hamstring stretch, the partner passively stretch the hamstring to the onset of discomfort. The athlete then perform isometric hamstring contraction against the partner's shoulder. The partner then passively stretches the hamstring further to point of discomfort. As we can see, the PNF hamstring stretch. Moving on to the general stretching program of gastrocnemius in the figure 6.5, as you can see, the pushing against a wall of fence with the leg straight out behind, feeling a gentle calf stretch. Here, as you can see, with the toe supported on a step or better elbow, heel to drop beneath the level of toe, allow gravity to impact the gentle stretch. Now, moving on to the soleus, supported by a wall of fence with knee slightly flexed, bring leg to the stretch underneath body and lunge forward. Again, feeling of a gentle steady calf and soleus muscle, particularly. As you can see in the D figure, hamstring with a leg supported on a beam or bench and keeping the leg straight, gently behind, forward, and the hips until a stretch is felt at the hamstring. Do not bend the back in order to get closer to the chest. Otherwise, the upper back is gonna involve. Rather than bending the hips with the back, keep the back straight. Here you can see the adductor stretch, groin sitting on the floor with knees flexed, soleus, soles of feet together and back kept upright. Gently push the outside of the knees toward ground until a stretch is felt in the groin. As you can see, an active quadriceps stretch in a standing position. Pull the heel to the buttocks until a stretch is felt at the front of the thigh. The stretch can be increased if necessary by pressing the hips forward. Attempt to keep the knees together and do not rotate the pelvis. There are some more example of the stretching, as you can see in the picture. Here's a groin stretch. The piriformis gluteus stretch, sitting on the floor, bend the left leg in front, place the left heel over the right thigh, the right leg, and pull the left knee towards chest until a stretch is felt in the left gluteal region that have piriformis. Attempt to keep both buttocks square on the ground. As a stretch for the lower back. As you can see, the tricep stretch. The arm into maximum flexion and abduction. Bend the elbow to fully flex position, then placing the opposite hand on the elbow to pull a gentle pull across back until a stretch is felt in the triceps and the shoulder. There's a pectoral stretch, as you can see. Standing or in a seated position, clasp both the hand behind back. Straight the elbows. The partner then lifts the hand gently. Keep the back straight. A stretch should be felt in the front of the shoulder and the chest. There is a stretch of levator scapulae. Stretch the levator. Place the chin on the chest and then rotate the head away from the side to be stretched. Then apply a stretch with the hand on the side of the head. A stretch should be felt in the neck and the shoulder. Next up, the taping and bracing. Taping or strapping and bracing are used to restrict undesired, potentially harmful motion and allow desired motion. There are two main indicators for the use of tape and bracing. First is the prevention. Taping is used as a preventive measure in high risk activities, for example, the basketball player's ankle. The rehabilitation, taping is used as a protective mechanism during healing and rehabilitation phases. Although taping and bracing are used in the injury management of condition in numerous joints, they have not have been proven to be effective or for primary injury prevention in the shoulder, elbow, knee, and special joints. However, there is a good evidence to suggest that bracing may prevent re-injuries in athletes with a history of previous ankle sprain or a ligament sprain. Taping. There are many type of different tapes and bandages available for use by athletes. However, when the purpose is to restrict undesired motion, only adhesive and non-stretch rigid taping is appropriate. The elastic tape is inappropriate for restricting motion. The good tape should be adhesive, strong, non-irritant, and easily torn by the therapist. The tape is ideally applied over the joint where skin sliding can be limited to one direction. The joint most suitable for taping for the ankle, wrist, finger, acromioclavicular joint, and the first metatarsophalangeal joint. Here are some rigid tapes and the kinesiology tape. As you can see, they come with a good permeability and extensibility, as well as providing mechanical support. Tape may enhance proprioception. Guidelines for tape application are preparation, application, removal, and complication. These tapes also provide the pain. They eliminate pain by the proprioception. So now we're gonna see the appliance application guidelines for the tape. The preparation. The athlete and therapist should be in the comfortable position for tape application. Tailor the taping to the need of an individual and then sport being played. It is important to provide support but not restrict essential movement. The injured ligament should be held in a shortened position during taping. Ligaments that have not been previously injured should be held in a neutral position. Shave the body hairs, preferably at least 8 hours prior to the tape application to avoid skin irritation. We clean the skin, remove grease and sweat so that the tape can't get fall off the skin. We apply an adhesive skin spray prior to taping, especially if sweating is likely to reduce the adhesiveness of the tape. Use an underwrap if a skin allergy exists. Care should be taken with use of non-stretch tape around the swollen joints. The use tape of appropriate width. There are some pre-wrap or unwraps that are important, which usually decrease the chances of skin irritation. The application, we use anchors proximally and distally as tape adheres better to itself than to skin. We unroll the tape before laying it upon the skin to ensure correct tension. Apply an even pressure on the both the surface. Then overlap the previous tape by 1/2 to ensure strength and even application. Smooth out all folds and creases to prevent blisters and lacerations. If a discomfort is present after tape application, adjust the tape. Here, as we can see, there are some eye anchors. We start by placing 2 anchors on the leg, one over the knee and under the knee. The anchors must be open behind knee in order to bloodstream is not blocked. Then we place a strip tape starting from the inside to the lower anchor, as we can see here, and diagonally upward across the knee joint and from the upper anchor. The tape must not be put on the kneecap. This is here to protect the knee. The same is now done starting from the upper anchor. As you all can see, there's a diagonal pattern at the knee joint. The taping application on example of ankle taping. This is a rigid tape to protect the ankle sprain or twist. The removal of tape carefully with the use of tape cluster cutters or tape scissors. Hold the skin and pull the tape slowly in position opposite direction. The complication of tape application include reduced circulation from tight taping, skin irritation due to mechanical or allergic phenomena, and decreased effectiveness of tape with time. A tape provides a substantial material support, as with any material does have a threshold where it fades. It may be necessary to reapply tape at a suitable breakdown during the athlete activity, for example, at halftime. The tape application requires practice to perfect technique. The bracing. Bracing has a several advantage over taping. An athlete can put a brace on by himself or himself, and although the initial cost of brace may be high, a good quality storing brace will last considerable time but may proven to be cheaper than repeated taping. Bracing also has a numerous of disadvantages. This include possible slipping of the brace during use, the weight of brace, problem with exact sizing and the risk of brace wearing out an unopportune moment. Sometimes it may be necessary for braces to be customized made. A number of different types of braces are available. Heat retaining sleeves are commonly used in the treatment of many chronic inflammatory conditions. These sleeves are commonly made out of neoprene. The neoprene support offers increased warmth and comfort over the affected area and may improve proprioception but provides little or no mechanical support. These sleeves are available for the joint and muscle. The increased mechanical support can be gained by the use of harder material or the addition of straps or laces. Certain braces are used to only restrict movement, such as hinged knee brace. There are This is an open patellar knee brace, a neoprene brace for the knee. The braces can be custom made by molding and thermoplasting material over the affected part. Such as flints are commonly used in the hand and wrist, particularly over the first metacarpophalangeal joint. After a Bennett's fracture or at the first metacarpophalangeal joint after a hyperextensive sprain or ulnar collateral ligament sprain. There are some molded braces. Thank you.